Welcome back again. We will speak about bladder tumor part 11. We will speak about the intravesical chemotherapy. Intravesical chemotherapy agents are DNA synthesis inhibitors that have a direct cytotoxic effect. Inhibition of the DNA synthesis results in cell death, particularly in cells within the high growth rate. So the cell with this appearance high growth rates, such as cancer cells. Intercalating agents insert into the DNA and after DNA is cut and prevent topoisomerase 2 from resealing the cut. This is the mechanism of action of the chemotherapy. So intercalating agents is inserted into the DNA of the specific cell. After the DNA is cut, it prevents topoisomerase 2 from resealing the cut. Intravesical chemotherapy does not change progression, time to metastasis, and overall survival. This will not change by intravesical chemotherapy. However, it does reduce recurrence rates. It is improved in reducing the recurrence, but have no relation with progression, time to metastasis, or overall survival. Intravesical chemotherapy is usually utilized for low-grade stage TA urothelial carcinoma of the bladder when the risk factor of recurrence are present. So the risk factor of the cancer, for example, the cancer multiple tumors or tumors more than 3 centimeters or recurrence within 1 year. For high-grade tumors and stage T1 tumors, BCG is more effective than intravesical chemotherapy. So this patient, low-grade stage TA urothelial carcinoma of the bladders, and the risk factor for recurrence are present at multiple tumors and tumors more than 3 centimeters or recurrence within 1 year, intravesical chemotherapy is usually utilized. Those for low-grade, high-grade tumors and stage T1 tumor, BCG is more effective. In the United States, mitomycin and gemcitabine are the most frequently used agent of intravesical chemotherapy, but in National Canadian Cancer, it's preferred that the gemcitabine because it causes less side effect and is less expensive. Gemcitabine is cause less side effect and less expensive. USA use mitomycin and gemcitabines most frequently used in USA. Treatment regimens. Both operative dose of single dose is administered intravesically within 24 hours, ideally 6 hours within 6 hours after 2 RBT. For the stage TA and T1 tumor, one post-operative dose of mitomycin C, gemcitabine, or ibuprofen. Ibuprofen is recommended. This for stage TA and T1 tumor. Okay, so one post-operative dose, only one of mitomycin, gemcitabine, or ibuprofen is recommended. When not contraindication, because it reduces the risk of recurrence. Absolute reduction rate in 5-year survival, it is 14%. This absolute reduction of the recurrence in 5 years, 14%. A single post-operative intravesical dose of chemotherapy is most effective in low-volume cancer, low-grade cancer, or stage TA cancer. This is a single post-operative dose for those groups, low-volume cancer, or low-grade cancer, or stage TA cancer. There is no benefit for patients with more than two or equal to recurrence per year, and also patient 8 tumors in the bladder simultaneously, large volume high-grade T1 cancer, that's more than 3 centimeters or multifocal, and or ureteric recurrence risk score more than 5, and also no proven benefit in patients with only CIS. So this is no benefit from the intravesical chemotherapy if the tumor more than or equal to recurrence per year, or 8 tumors in the bladder simultaneously, or large volume high-grade T1 bladder tumor more than 3 centimeter or multifocal, ureteric recurrence risk more than 5, and no proven benefit in patients with only CIS for chemotherapy. Varoglucine and thiotepa are not used in this setting. Induction course, a cycle of intravesical chemotherapy starting 3 to 4 weeks after TURBT. The initial induction course typically consists of intravesical instillation of every week for 6 weeks. This is the first induction dose for 6 weeks. Maintenance therapy may be used after induction. Okay, so the regimen is usually on instillation every 1 to 3 months for up to 1 year. So 1 to 3 months for up to 1 year. This is for maintenance of chemotherapy. Contraindication or to intravesical chemotherapy when urethral integrity is disrupted or the local and systemic toxicity are more likely to occur. This is a contraindication to intravesical chemotherapy. If we have disruption of the urethral integrity, or if we have toxicity, local and systemic toxicity, and therefore this agent should not administer when any of the following presents. That's the integrity. For example, we have a known or suspected bladder perforation. Intravesical chemotherapy should not be administered when the bladder perforation or extravasation from the bladder is present or suspected. Also, if the patient have recent extensive transurethral resection, TURBT, recent extensive transurethral resection within the past 1 week. Okay, so current urinary tract infection also it's a contraindication, as well as TURBT within past 1 week. Gross hematuria, clot that might hinder the draining of the bladders of the bladder of the intravesical chemotherapy. Traumatic catheterization also is contraindication. Before starting a course of therapy, ensure that the patient does not have a urinary tract infection, very important. Advise the patient to limit fluid intake for 8 hours before each instillation to avoid rapid dilutions of the chemotherapy. So avoid drinking a lot of water before 8 hours before the induction of the chemotherapy. This to help the patient holding the drug for long duration. When using mitomycin, consider oral methods to alkalize the urine before each instillation. So it is better to use alkylinating agents or alkalizing agents before mitomycin therapy. Mitomycin is more effective at pH more than 6. So it is alkaline agents. Alkaline agents, this is a mitomycin, so it's work better in alkalizing or alkalizing media, pH more than 6. For example, administer 1.3 grams of oral sodium bicarbonate the night before, the morning of, and 30 minutes before each instillation. Very important. Instillation technique immediately after TURBT. Do not instill the chemotherapy if it is contraindication. Empty the bladder, place a catheter and instill the chemotherapy agent into the bladder. First, we will empty the bladders, and then through the catheter, we will instillate the chemotherapy agent into the bladder. The agent is held into the bladder, ideally by raising the catheter drainage bag above the patient. This for 2 hours until the patient becomes uncomfortable. And after that, after draining the bladder, the catheter, after that we drain the bladders, and after draining the bladder, the catheter may be removed. Instillation technique for subsequent therapeutic and maintenance cycles. Before each instillation, the patient voids before each instillation. Very important. Empty the bladders, perform urine analysis to check for gross hematuria and urinary tract infection. When the catheter is placed, both void residual is measured. So when this was void must be measured. The bladder should be empty completely before each instillation. Instillation infused through the catheter and into the bladders. After each instillation, attempt to hold the agent in the bladders for at least 2 hours. The body position may be varied to ensure through distribution in the bladder. So the body position, the patient must be rolled side by side on his tummy, on his back, and stand up. All this, it is actually allowed distribution of the chemotherapy to the bladder tumor. If the patient has high post-void residual, consider catheterizing the patient 2 hours after instillation to prevent prolonged exposure. Patients should wash their hand and genitals after voiding. Refraining from the 6 from 6 for 48 hours. So refraining from the 6 or stopping the 6 for 48 hours. Very important. This is the end of this lecture. We'll meet again in another one. Bye bye.